I'm Lauren Tardo. A lot of you probably know me from residency, from fellowship. I just recently finished my fellowship in neuroimmunology here and have come on and stayed on staff in our neuroimmunology department. My specific focus is multiple sclerosis, but as you'll see, and as I'm sure you know, there's a lot more to neuroimmunology than just MS. And so today is kind of gonna just be a broad overview of demyelinating disease. I'm gonna go over the most common, which is MS, spend a little bit of time on some other ones, give a broad talk on TM, and then talk about a few other things. Again, trying to think of how this would be helpful for you guys. You guys see a lot of our patients. There's some of our patients on y'all's floor now, and we throw out a lot of these terms in terms of diagnosis and treatment and, pseudo exacerbation. And so I thought that, kind of a broad overview of all of this would be helpful, as you guys are, an integral part of our patients' recovery process. So just to start, we'll start with multiple sclerosis. And so it affects approximately 1 million patients in the United States. And this is a lot larger than what we had previously thought. Previous numbers were cited around 400,000. And then more recently, newer studies have shown that it's actually probably about 1 million in the United States alone. It's one of the leading causes of atraumatic disability in young adults, and this is why you guys are such integral parts of these patients' care. In terms of age of onset, it ranges, if you look in the literature, anywhere from 20 to 40, but I will say that, there are extremes to this. We have a very large pediatric multiple sclerosis population over at Children's, and then we also have patients who present, well into their 50s and 60s with a first attack. So there are extremes to this, but in general, when you look at the literature, age of onset is going to be anywhere from age 20 to 40. It tends to be more common in females than males. And then right off the get-go, when we see a patient, there are a few things that help us know, is this going to be a more severe or aggressive course that sets a patient up for more disability. And those specific things are being a male, non-Caucasian population, so specifically Hispanics and African American patients tend to have more aggressive disease courses and hit higher levels of disability faster. Also being an older age at onset. Another one is having spinal cord syndrome at onset. And then another one is high early relapse rate. So meaning when we diagnose someone within that first year of diagnosis, if they tend to have multiple relapses, that tends to portend a worse prognosis in terms of long-term disability. In terms of the pathogenesis and the risk, so the risk in the general population is about 0.1%. In terms of the pathogenesis, there's not, one specific thing that causes MS. It's probably a little bit of genetic susceptibility, plus a little bit of environmental factors that create this perfect system for a patient to develop MS. In terms of genetics, and if you have a first degree relative with multiple sclerosis, there's a 2 to 5% risk that you will have it, or if you have it, that your children will have it. In terms of monozygotic twins, this goes up significantly to 20 to 30%. So again, you can see there is some heritability here. And this isn't important for you guys, but our residents often get asked about what HLA locus portends a higher risk. And so those exist. This is the one that's most commonly cited, but there are others, and there are also some protective ones. In terms of the environmental exposures, again, the list is pretty long, but the big ones are EBV. EBV exposure has consistently been shown to increase risk for developing MS, and it's actually about 2 times that of the general population if you've been exposed. Other things are UV exposure and vitamin D. Specifically, vitamin D is protective, and this was discovered as they did studies and found that MS tends to be more prevalent in those areas in higher latitude, so the further you get away from the equator. Another one is obesity, and this is specifically talking about childhood and adolescent obesity. It tends to be more associated with an increased risk of MS than obesity in adulthood. And then finally smoking. And here this is dose dependent, meaning the more you smoke, the higher the risk of developing MS. Again, it's not one of these things. It's probably a few of these combined that create the perfect situation, and then a patient presents. So a genetically susceptible individual has some sort of environmental trigger, and then MS manifests. And it manifests in immune-mediated attacks that specifically attack the myelin. And so the way that I like to describe MS or demyelinating disease in general to my patients is I talk about an old-timey phone cord. So if you remember, they had the copper wire, and then they had the rubber insulation. And so in demyelination, some sort of immune attack occurs, and it attacks the myelin. And so in the illustration, it attacks the insulation around that phone cord. And so the signals can't get through. And so that's kind of my layman's term for when I'm telling a patient, what does it mean to have a demyelinating disease? That's what's happening. In terms of the diagnosis of MS, it can actually be pretty challenging at times. The initial diagnostic criteria were created in 1965. They were called the Schumacher criteria, and then they've been updated multiple times by Poser, and then McDonald took over. And most recently, we had the 2017 McDonald criteria. And with each new addition to this diagnostic criteria, it allowed us to diagnose MS earlier, which is important because now we know that the earlier we start these patients on treatment, the better chance we have of delaying or not progressing to long-term disability. And the diagnosis is specifically based on dissemination of a central demyelination syndrome in both time and space. And I'll explain what that means in a little bit. But if a patient meets these criteria, and then with a caveat that I'll talk about at the end, this is about 85% sensitive and specific for diagnosis of MS. So what do I mean by dissemination in space? And so basically what I'm saying is that we want to find lesions in at least 2 of these distinct anatomic locations on a patient's MRI. And so juxtacortical, meaning that it completely, it abuts the cortex. Periventricular, meaning that it comes down and touches the ventricle. If you probably remember this kind of classic picture from shelf exams, these are Dawson's fingers. Infratentorial, meaning below the tentorium, so brainstem or cerebellum. And then finally, spinal cord is all lumped together in one. So again, you want to find lesions in 2 different areas from this list. And you'll notice that optic nerve is not on here. And there's been arguments at all the meetings about this, and it still has not made its way onto this space criteria, despite it being a common presentation for our patients. In terms of dissemination in time, so our patients can fulfill this multiple different ways. So the easiest way to do it is there's evidence of another attack outside of the original attack. Another is based on MRI. So if we scan a patient and we see both enhancing and non-enhancing lesions, that also tells us that, you know, there's an acute episode, but there's been another attack that maybe was asymptomatic, but it's just further evidence that this isn't new, this has been ongoing. Or oligoclonal bands. And these are not specific for MS, but with the criteria, this specifically has allowed take a patient who maybe doesn't meet criteria for time because they've only had 1 attack and they don't have, you know, different lesions at different ages. We do a spinal tap and we find oligoclonal bands. We can diagnose them with MS. Again, not specific, but it's very helpful in diagnosing these patients earlier. And then the one caveat that I'd like to put on this is that a patient may meet all these criteria, but there's got to be no better explanation. And what do I mean by that? So basically that means that the differential diagnosis for multiple sclerosis is quite large and quite broad. I am sure that you some of our MRI reports from our radiologists that say could be microvascular changes, could be nonspecific, could be a tumor, could be demyelinating, could be vasculitis. So all of those things can look like MS on an MRI. And so you just have to really make sure that there's not a better explanation for why this patient is presenting. Some of the ones that can be the most frustrating on this list are small vessel disease. So older patients can get nonspecific changes related to small vessel disease. They can also just be nonspecific in general. Our migraine patients can sometimes have abnormalities on their MRI that don't necessarily meet criteria, but it prompts a trigger for them to be referred to us for an MS evaluation. And a lot of times patients have a lot of non-specific symptoms that our MS patients have. So you really have to have your detective hat on and think about, is this really MS or could this be something else? And so again, this list is not inclusive, but these are a lot of the things that we consider whenever someone is coming to us for an MS evaluation. In terms of the different variants of multiple sclerosis, so there's 5. I'm only going to talk about 3 of them today. The most common is relapsing remitting multiple sclerosis. So, probably 80% of our patients fall in this category. And it's defined by these discrete episodes or relapses of new neurological deficits or worsening of a prior deficit. And so that's followed by recovery. And so this graph illustrates it nicely. So a patient is at a normal, their disability status is 0. They have a relapse, so they have a transient increase in their disability status related to a new neurological deficit. This can persist sometimes for months, even in the setting of treatment. And then they go back to their original disability. It's important to note, though, that recovery can be complete, meaning they go all the way back to normal, or it can be partial, meaning they don't fully recover. And so even outside of a relapse, these patients can still accrue disability from these partial recoveries from these relapses. Again, the recovery phase can take anywhere from 3 to 6 months. Sometimes we see, more expedited recoveries, when we do steroids and plasma exchange, but sometimes it can linger. The next one is secondary progressive MS. And so these are our patients who have relapsing remitting multiple sclerosis and transition into a progressive phase of the disease. And so this graph illustrates that we had a patient who was previously in relapsing remitting, but at some point they transitioned to where they steadily accrue disability outside of a relapse. Previously, approximately 80% of our patients would transition into this phase. We've gotten a lot better at stopping this now with a lot of our new therapies that are considered highly efficacious. But again, this is a big deal because this is whenever patients really start to accrue disability despite not having a relapse. And it should be noted, again, not as important for you guys, but patients can still have relapses within this category. But the big picture is that they're obtaining disability outside of that as well. The next one is primary progressive MS. This is probably the least common in terms of our symptomatic patients. And this is defined by at least 1 year of continued progression at disease onset. And they have to fulfill the criteria that we talked about earlier. But again, the big thing is at least 1 year of just steady disability accrual. They can also have relapses, but the big picture is that their clinical course is defined by their just steadily accruing disability over time. And to meet criteria, technically this needs to be ongoing for about a year. This is typically diagnosed later in life, but not always. And here, whereas in general MS is more common in females, here it's equal between males and females in terms of this specific variant. In terms of some of the typical presenting symptoms, so one is optic neuritis. Specifically in MS, it tends to be unilateral. Patients will typically have pain with eye movement and then go on to develop central blurring. And this is to kind of illustrate what a patient may see. And so you can see in the good eye, colors are crisp, normal. In the bad eye, there's central blurring. And then another phenomena that we commonly see is called red desaturation. So patients may say colors just aren't as crisp as they used to be. And this is most noticeable with the color red. And so you can see that here. Other common presenting syndromes are brainstem syndrome, so trigeminal neuralgia. Any young female that presents with a new episode of trigeminal neuralgia at least needs an MRI brain to make sure that this isn't a first manifestation of multiple sclerosis or some other disease. Another one is INO, which is internuclear ophthalmoplegia, which is a common eye finding that we see in our MS patients who have brainstem involvement. They can also present with cerebellar syndromes, so with varying degrees of ataxia, as well as varying degrees of nystagmus. And then finally, they can present with transverse myelitis. Typically in MS, their myelitis is partial myelitis, meaning only part of the cord. They commonly get this phenomena called Lhermitte's sign, which I'll talk about in a little bit in a few slides down. And typically with MS, they get more sensory loss than motor loss. Not to say that our patients don't get motor loss, but typically it's sensory loss. And this is just to kind of illustrate an episode of partial myelitis on MRI. So you'll see that it's not the whole MRI, so partial. And we'll talk, when I talk a little bit more about TM or transverse myelitis, I'll show you some classic areas of the spinal cord that MS tends to like. In terms of MS treatment, so acute relapses are typically steroids. With the steroids, it's usually 3 to 5 days of high dose. We can do this IV. So if a patient is in the hospital or on the rehab floor and we think that they're having a relapse, we can give them 1,000 milligrams of Solu-Medrol daily for 3 to 5 days. However, in our outpatients, we really try not to admit these patients unless they're having optic neuritis or they're having a spinal cord syndrome, because PO, Decadron, and prednisone is equivalent in terms of being able to help with this. So we've gotten a lot better at keeping these patients out of the hospital for minor relapses. Typically the ones that you guys are going to get from us in the inpatient setting are going to be the ones that had severe relapses and that we brought in for steroids or plasma exchange. In terms of the plasma exchange, it's typically reserved for those who don't respond to steroids or patients who can't tolerate steroids, so who have osteonecrosis or just can't tolerate them. We'll go straight to plasma exchange, but typically plasma exchange is for those patients who don't have a good response to steroids, and typically we do anywhere from 5 to 7 exchanges there. And then in terms of long-term treatment, so currently, and it may be higher, there are 18 approved therapies. One was approved last week, actually, and it's crazy how many are actually in the pipeline right now in terms of long-term treatment. And the goal here is immunosuppression or immunomodulation. In terms of the different types of treatment, so we have injectables that vary anywhere from a daily injection to a weekly injection to a 3 times per week injection, to oral therapy, and this varies anywhere from a pill that you take once per month for 2 months and then nothing for a year, to a daily pill, to a twice daily pill. And then infusions, which are kind of my go-to favorites. I know I'm not supposed to have favorites, but these are my favorites. And these are things like natalizumab or Tysabri and Ocrevus. And these tend to be our highly efficacious medications. And again, our goal here is immunosuppression and immunomodulation. But this term that has kind of come about in our world is NETA, or no evidence of disease activity, meaning both clinically. So my patients aren't having relapses. I'm not getting phone calls about new neurological events, and then also radiographically. So these patients are getting yearly MRIs outside of, new symptoms. It's just a yearly MRI. And so they may not have a clinical relapse, but they also cannot have radiographic progression, meaning I don't want to see any new lesions. I don't want any evidence that their immune system is still going awry and attacking. And so NETA is kind of our word for remission in MS. And we've actually gotten a lot better at putting patients into this status than we were 20 years ago, because we have so many therapies. And like I said, there's so many in the pipeline, it's a little overwhelming even for me, keeping them all straight. And then I can't imagine for my patients as I, present them with, oh, here's your 18 options, which one do you want? And so for me as a provider, I really try to pick a few that I think are good options for patients and then walk them through that decision. There are other providers who will, say, this is the one I want you to take. For me, I like to give my patients a little bit of an option, but narrow it down some for them. In terms of, a lot of the chronic symptoms that we see in MS outside of relapses, this list is not exhaustive, but fatigue, spasticity, insomnia, chronic pain, GU dysfunction, sexual dysfunction, gait difficulty, cognitive changes, and then depression and other mood changes. A lot of our patients are followed in the PM&R clinic for some of these things specifically. I wanted to touch on a few. I think y'all are going to have another lecture about some of the symptom management. Probably spasticity, if I had to guess. Dr. Shaw is wonderful. We send a lot of our patients to her for that specifically. But in terms of fatigue, this is probably the #1 complaint in our patients. It affects approximately 80% of them. The unique thing about MS fatigue is that it's typically present early in the day and worsens throughout the day. It interferes, even with simple household tasks. Or my patients will say, I washed the dishes when I woke up and I felt completely wiped. And so that's a pretty specific type of fatigue, as opposed to our fatigue where 3 p.m. we hit our kind of lull in the day. They're fatigued, all the time. In terms of how we, address this, we really want to rule out secondary causes. So things like depression, insomnia, which is also a common problem in our MS patients, and then also medication side effects. And once you've ruled those out, then you can go down a pharmacologic route in terms of the different options that we use. We'll use methylphenidate, Vyvanse, Impura, which is the 4-aminopyridine, and it's actually an agent that we used to help with walking speed, but another added benefit is that it can help with fatigue. And then also low dose naltrexone. I will say I've never prescribed low dose naltrexone, but it is something that we do. We also sometimes use amantadine as well. I typically will do amantadine before I go down the route of controlled substances, just because of the hassle. And then once the patient tends to start, one of those controlled substances, it's a lot harder to get them off of it. And then there are also non-pharmacologic options that we'll use. One of those is N-acetylcarnitine. We'll sometimes do that. I've had some patients who said it did nothing, and I've had some patients who say that it helped, but it's also something that we can try. In terms of the cognitive symptoms in MS, again, this is very common, and a lot of times we miss this in our evaluations because we don't ask about it, and you may not pick up on it just on a general exam. The specific domains that are affected in MS tend to be attention, executive function, processing speed. That's a big one. And then short-term memory. Another common thing that we get from patients is that, they forget names. They, can't come up with, they know what they want to say, but they just can't get the words out, or they think they're saying potato and they say cantaloupe. And so that's a pretty common thing as well. In terms of treatment, there's no proven therapy. Big thing here is to first address anything that can be contributing, same as with the fatigue. Depression can certainly make cognitive symptoms worse, pain can, fatigue can. And then in terms of non-pharmacological options, it really depends on, family support, coming up with ways to circumvent this. So lists, calendars, reminders, ways to set them up for success despite, these cognitive symptoms that they're having. Another big one, and probably the most frustrating for us, is pain in MS. Pain is very difficult to treat. There's multiple different types of pain. So in terms of paroxysmal pain, these tend to be things like trigeminal neuralgia, which is, the electrical shock-like pain in one of the facial distributions, so V1, V2, or V3. Or another thing is tonic limb spasms that we see a lot in our patients who have spinal cord involvement. And this is where patients will, and you may have heard this, a patient will report involuntary painful episodes of flexion, typically triggered by movement. I think I most commonly hear about these. The patients will say, I go to lay down in bed at night and I have flexion of an extremity and it's painful. Another, type of pain that we see is more persistent type of pain. So paresthesias can be annoying, but can also be painful to patients. And then spasticity. In terms of treatment, there's a huge, list of medications here. For more of the paroxysmal type things, we tend to do things like our seizure medications, so carbamazepine, Lamictal. For the, neuropathic paresthesias, things like duloxetine, gabapentin, Lyrica. spasticity, just depending on the patient, so baclofen, or we'll usually send them to you guys for local Botox injections, or for baclofen, intrathecal baclofen pump evaluation if it's severe and that's something that they could benefit from. Again, Dr. Shah's group is wonderful at this. And so now I just want to go over a couple things that you might see. And I think I talked to one of y'all this week about one of these phenomena and one of our patients that's on the 6th floor at Zell right now. So we have a 5-year-old who has a history of multiple sclerosis and a prior history of optic neuritis. And they come in with worsening vision in the setting of an intense workout. So what's the next step here? Do we treat them with IV steroids? This is an MS relapse. Do we admit them for observation just to kind of give it time? Do we do nothing just because there's nothing to do? I'm too busy. Or do we apply ice packs? And I can't see the chat box. So I'm just gonna.
Yeah, it looks like there was one of the 6th floor Zell residents said ice packs.
Yes. Yes. I don't think we did that with that specific patient, but yes. So the answer is ice packs. And so this is a phenomena called Ufthoff's phenomenon. And so it's when a patient experiences transient reversible neurological deficits. And these occur classically with increased core body temp. So stress, a hardcore workout, infection, sometimes menstrual cycles. And the key here is that it's typically less than 24 hours or until that provoking factor goes away. And a lot of times this is termed a pseudo exacerbation. So with the patient on the Zell 6th floor, I think she's got an infection right now and is reporting maybe some increased eye pain. And so the question is this new disease? It's hard to say. Typically we don't scan these patients if they call in from outpatient and say, hey, I'm having these new symptoms, but I have a UTI. We typically don't scan them until we've proven that these symptoms persist outside of adequate treatment. When someone's in the hospital, it's a little bit easier to just get an MRI. So, we may fudge that a little bit on the inpatient side, but on the outpatient, typically we'll want to ensure that the infection is treated first before we go down a route of possibly treating for an MS relapse. Any questions about that specifically? I don't think I saw any. Okay. So the next one is another common phenomena that we see. So you have a colleague who has a known history of MS, and she's presenting to med students when she drops her rounding cards. She looks down to pick up the card, so she flexes her neck, then shouts in pain and falls down. Never weak, and was kind of able to quickly, gather herself. She later goes to the ER where what she tells you is that she felt an electrical kind of lightning rod strike her back at the time of the fall, and it radiated into her back. And so what is this? Is this, she's got, degenerative disc disease, it's just a bad disc? Is this MS relapse? Is this Lermite's phenomenon? Or is this an actual lightning strike?
I mean, as tempting as D is, there's a lot of C in the chat.
Yeah, so correct. So this is Lermite's phenomena. And so Lermite, let's see, is this going? There we go. So Lermite's phenomenon is a patient-reported kind of symptom of they feel an electrical shock that radiates down their spine or into their extremities. This is typically caused by neck flexion, and it's thought to be due to an old lesion, and when you stretch it, it's hyperexcited, and so that's where that electrical shock sensation comes through. In terms of, when this occurs, so it's not specific for MS, we commonly hear it, but it can also pretty much happen with anything that can cause spinal cord injury, so Chiari's, or anything that can cause the type of stretch, so Chiari's, disc compression, things that cause metabolic spinal cord disease, so B12 deficiency or nitrous oxide abuse, anything that can injure the spinal cord. Whenever you do that movement, it can cause that. And I've caught myself, a lot of times flexing my neck just to make sure that I don't have this. And I've sometimes convinced myself that I do. And I don't. So just be aware. In terms of another demyelinating condition, so the next one is neuromyelitis optica. Go ahead.
Tardo, there was one question about, is it always an extreme electrical shock sensation, or is it sometimes mild?
So it's really patient reported. And so how does the patient perceive it? So no, some patients will just say, I get discomfort when I do this and it shoots down into my arm or my spine. If you read the textbook, the classic description is that it's excruciating, but I've had some patients tell me that it's not excruciating. They just get that sensation every time they do that. Does that make sense?
Yeah.
So the next demyelinating disorder I wanted to talk about is neuromyelitis optica. And so this is an inflammatory demyelinating disease of the central nervous system, but I want you to make a point to remember this is a distinct entity from multiple sclerosis. And it's important to know this because our treatments for MS can actually worsen this disease. It's a little less common than MS. Its prevalence is approximately 4 per 100,000. Again, it's more common in females than males. And here specifically in terms of pathogenesis, it all kind of circles around, not all, but for the majority of patients, circles around the presence of the aquaporin 4 antibodies, which I'll talk about here in a minute. And these can be found in approximately 80% of patients. Again, it can occur at any age. Median onset is around 40 years, but we have a very, not large, but we have a significant population at children's of these patients as well. Here, it tends to follow a relapsing course as well, but it should be noted that these relapses tend to be very severe. And then another key difference from MS is that whereas in MS, progression can occur independent of a relapse. Progression here really only occurs in the setting of a relapse. Only is not the right word, but in general occurs in the setting of a relapse. In terms of the aquaporin 4 antibodies, so again, like I said, these are found in 1% of patients with NMO. And if you remember back, these aquaporin 4 channels are kind of found throughout the body, but also in the central nervous system, tend to be around the perivascular spaces, on the astrocytic foot processes, and most concentrated in the optic nerves, the spinal cord, and the area postrema, which will be very important for whenever I show you the typical clinical manifestations of these of NMO. In terms of what happens, so the antibody binds to these channels and it leads to an inflammatory event. So the complement cascade is activated, inflammatory cells come in, and it triggers this train of events that leads ultimately to demyelination. In terms of the clinical manifestations of NMO, so optic neuritis tends, if you look in the literature, is probably the most common presenting symptom. Real world experience, I don't know that I would say this just from my personal experience. I've seen kind of across the board presentations. Typically with NMO, unlike MS, it's going to be bilateral, and it's going to involve the posterior optic pathway, meaning retroorbital, and then also you can get chiasm involvement. And here, unlike MS, the vision is typically significantly more severe, and a lot of times patients will experience complete visual loss in NMO. Another common manifestation is transverse myelitis, and it, again, a broad term, so it doesn't, transverse myelitis itself isn't necessarily specific to a disease entity. In NMO, the unique thing is that it tends to be longitudinally extensive, meaning that it's going to span more than 3 vertebral segments. And so you can see in this MRI, you see this hyperintensity that kind of extends all the way from C1 all the way down to what you can see on the screen, so mid-thoracic. Again, these attacks tend to be more disabling than what we see in MS-related myelitis, and the recovery also tends to be less when compared to MS, even with our best treatments. Another common clinical manifestation is area postrema syndrome, and so this can lead to intractable hiccups or intractable nausea and vomiting, and really with the absence of any neurological symptoms. And so this can actually lead to misdiagnosis initially, because sometimes the patients will end up in a GI doctor's office for workup of this intractable nausea or PCP, and it may take a little while to come to the diagnosis. So anytime you see someone and they're saying, I can't stop hiccuping, or I'm just nauseated all the time, it's just something to be thinking about. In terms of the diagnostic criteria, don't get bogged down in this. I just really wanted to call attention to the fact that you could be diagnosed with this with or without the aquaporin 4 antibodies. Those that have the antibodies, it's much easier to diagnose, whereas those who do not have the antibodies, it relies on a little bit more stringent criteria, but we have both antibody negative and antibody positive NMO spectrum patients, so just be aware of that. In terms of treatment, so similar to MS, steroids, I will say here we tend to rely a lot more on plasma exchange because again, these relapses tend to be very severe. In terms of long-term treatment, typically we use agents like Rituxan, Cellcept, or Solaris, and again, there's multiple in the pipeline here as well. The next one that I want to touch briefly on is myelin oligodendrocyte glycoprotein immunoglobulin associated disease, and that's a mouthful, so we're just going to say MOG. This is kind of the newcomer to our world in neuroimmunology. It's kind of the hot topic. A lot of research is being done here. And so MOG is a component of myelin protein. It's expressed only in the central nervous system on the oligodendrocytes, and if you remember, they're responsible for myelination.
Get some sleep.
This was found to be an antigen or a target for demyelinating disease over 30 years ago, initially thought to be a disease marker for multiple sclerosis, but with the invention of better testing modalities, we actually found that it was a distinct entity. One thing different here between the other two is that it tends to be more equal between females and males, although in more of the larger cohorts, there does seem to be a female preponderance. In terms of MOG antibody-mediated disease, the presentations that we're seeing tend to vary based on patients' age of presentation. And so in our pediatric population, we see a lot of ADEM type presentations, which I'll talk about in a minute, whereas as patients are aging or we're presenting at older ages, we're seeing different phenotypes with opticospinal, so meaning optic neuritis, or transverse myelitis, or both. And then more recently, encephalitis with seizures has been described in these patients. In terms of treatment, so again, looks very similar to our other ones. Acute relapses really rely on steroids. And one of the unique things about MOG is that it tends to be very steroid responsive. We still rely on Plex at times, but kind of the buzzword in our world for MOG is steroid responsive. In terms of the long-term treatment, it's really unclear, if we even need it, as some of these presentations are monophasic. There's a lot of research ongoing here in terms of, do we treat these patients or do we wait? Some people argue that because they're so steroid responsive, why would we set a patient up for lifelong immunosuppression if we don't know that it's going to happen again? And so again, the jury's still out here, and you'll see varying opinions at all the academic institutions among even investigators at academic institutions. But when we do treat, typically rely on similar agents, Cellcept, Rituxan. There's a big push for IVIG also in this patient population now as well. I'm going to touch briefly on transverse myelitis, and I want to talk about this because I think that the term gets used inappropriately. So it's a very broad term, and it's really referring to any inflammatory event of the spinal cord. And so there are multiple different causes. So demyelinating disease, so the ones that we've already talked about, infection causes such as HSV, zoster, West Nile can do it. There are also other inflammatory conditions that can do it, such as lupus, which is the great mimicker in our world, and then connective tissue disorders. And then if all else fails, sometimes patients will fall into this category of idiopathic transverse myelitis. And I want to call special attention to vascular myelopathy because we've had a few of these this year actually, and it's a distinct entity. So yes, it's a spinal cord event, but whereas in transverse myelitis, there's an inflammatory event, in vascular myelopathies, it's really due to a blood flow problem. So we're not perfusing the spinal cord, whether it's acutely or chronically over time. So just be aware, it's a distinct entity that sometimes gets lumped into transverse myelitis, but it's really not. In terms of the different presentations of transverse myelitis, it's really dependent on the spinal level and what tracts are affected. So I'm going to go into that. And when I was looking for board style type questions for you guys, this seemed to be more of a hot topic. than pathogenesis of multiple sclerosis. So I broke this down a little bit, and I'm sure you guys all know this, but this was also a good reminder for myself. In terms of anterior cord syndromes, so you're going to hit your anterior horn cells, and so patients will get flaccid weakness. You'll get your corticospinal tracts, which will be pyramidal type weakness, but there's some overlap there because if you're hitting your anterior horn cells, you'll also hit your spinothalamic tract, so patients will have loss of pain and temperature below the level. Depending on the level of the cord, you may also hit your autonomic tracts, and so patients will lose control of bowel bladder. The thing to note here is that it tends to spare the dorsal columns, so those remember carry vibration, proprioception, joint position, fine touch, and so patients will tend to have that preserved, although that patients don't always follow the textbook on this. And the big thing with this in terms of causes is anterior spinal artery occlusion. So acute onset cord presentation, think anterior spinal artery occlusion. In terms of posterior cord syndrome, so this gets the bilateral posterior columns. Here, remember, it's carrying joint position, fine touch, vibration. So those things are knocked out. Common things that cause that are metabolic things like B12 deficiency, copper deficiency, zinc excess, which is indenture cream, so be careful, or nitrous oxide abuse. We've had a few of these over the past few years where people were abusing whippets. So with the spray whipped cream, nitrous oxide is what is used to power that. So patients will get high off of that and then come in with a myelopathy, specifically posterior cord syndrome. And then another thing is MS. So MS loves the posterior columns. And so when I say partial myelitis, sometimes we'll see lesions isolated to that posterior portion of the spinal cord. In terms of central cord, this gets your crossing spinothalamic tracts. So patients will have loss of pain and temp. You'll hit your corticospinal tracts as well. And so you can get pyramidal weakness. Again, you may or may not hit the autonomic fibers. This tends to be things like NMO. It loves the central cord. Things like syrinxes can also present like a central cord syndrome. So just be aware of that. And then just briefly, a case to just kind of wrap all of those syndromes up. Again, this seemed to be the high yield topic kind of for transverse myelitis is where the lesion is located or what portion of the cord. And so this one is a 26-year-old female who comes on with sudden onset back pain, followed by rapid lower extremity weakness and sensory loss. So I'm talking, you know, within a matter of minutes. On exam, she has loss of pinprick sensation up to the mid torso. So what does this sound, you know, most consistent with? And I can't see the chat box, Lauren, if you just want to say.
Yeah, I know. I'm waiting for some responses.
And she's got spared proprioception there.
We got a lot of takers for B.
Yep, so the answer is B. So this is anterior cord syndrome. And this is actually pretty similar to a patient that was just there at Zell. And so one thing I want you guys to hear in this story is sudden onset, boom. I can tell you that at 11 a.m. on Friday, I had back pain, I got weak, and this all, you know, peaked within a matter of minutes. It's vascular until proven otherwise, okay? A lot of times these patients will get clumped into a transverse myelitis category. But with that story, hyperacute, you got to be thinking vascular. Again, a lot of times the management, you know, may not change anything, but just be aware of that because I think a lot of times people forget about that being a cause for spinal cord events. Let's see. In terms of TM recovery, it really varies based on the underlying cause, like we've already talked about. MS tends to have a better, you know, response to treatment as compared to NMO. MOG also tends to respond better than NMO. Idiopathic, it's just variable depending on, you know, their response to the treatments. And then again, I want to point out vascular myelopathy because it's a distinct entity that can sometimes present this way, but a lot of times these patients tend to have less recovery than our inflammatory TM type patients. and they don't respond to steroids and plasma exchange like these would. So just be aware. And when I say vascular myelopathy, the things that I'm like specifically referring to are spinal cord infarcts, dural AVFs, or things like fibrocartilaginous emboli, which we think we had one recently there on y'all's floor. Very rare, but we see it, and it's just something to be aware of. Just a couple more. So a quick case, just in case you ever come to the ped side. So there's a 6-year-old boy who comes to the emergency room. He's fussy, he has a fever, and his parents say he's had a headache. When he comes in, he's weak on one side. He becomes increasingly encephalopathic and ultimately requires intubation. He gets imaging study in the ER, and this is what you see. So pretty diffuse brain involvement. He's got thalami involvement, and then he's got a longitudinally extensive lesion. And so this is ADEM. And the reason I want to talk about ADEM is because we see a lot of these at Children's that end up in our children's house, that a lot of you guys are actively involved in, so just be aware of it. So this is our kind of our pediatric demyelinating disease, although MS and NMO and MOG all happen in the peds population as well. This is typically monophasic, meaning that we don't put these patients on long-term therapy, although, not always the case, but typically monophasic. The acute treatments tend to be pretty identical to how we treat, our acute MS relapses, steroids, Plex, sometimes IVIG. And then just to point out that MOG has been kind of discovered to be one of the big culprits behind ADEM, and we didn't know this before. So that's kind of a new hot topic in our world. And then just to kind of close, just be aware that there are systemic autoimmune diseases that are associated with demyelinating disease. So lupus loves to cause, neuropsychiatric symptoms, but also things like transverse myelitis. It can mimic MS. Sjogren's syndrome also loves to cause transverse myelitis. It can actually have occur concurrently with NMO, antiphospholipid syndrome, and then Behçet's disease is another one. Not really autoimmune, but inflammatory, is neurosarcoid, loves the spinal cord, also loves the meninges in the brain. So just another thing outside of isolated CNS disease, there are a lot of these conditions. And that's really all I've got, kind of a rapid fire demyelinating disease, because we throw these terms out all the time with our patients just to kind of make you all aware. And these are my dogs who are currently, like I said, in their kennel because they are being crazy today. So Hank and Duke. Hank is 2 and Duke is about to be 1. Hank's a golden doodle and Duke is a pyrodoodle. So he's half Great Pyrenees, half poodle. And he's massive. He's 65 pounds and only 10 months old. And so I'm a little worried that we don't have enough house.
Oh my goodness, they're so cute.
They're a mess.
Well, I bet, but a Pyrenees and a golden doodle, who would have thought?
Yeah, apparently it's a thing. We rescued him, but apparently it's actually a thing that people will pay a lot of money for.
Okay, does anybody have any questions? You can put them in the chat while we wrap up here, but this was great, Dr. Tardo. Thank you so much for.
Absolutely. And if there's any questions, feel free to shoot me an email too. And again, always stop us, because like I said, there's a lot of overlap in our patients and you guys. And so if we have someone on your floor and you're like, hey, you keep throwing out this term, what do you mean? Please stop us, because this is important, because y'all are an integral part of these patients' lives and their recovery. And so just stop us, ask us. We all throw out, I think opto is probably the worst, throw out these really rapid fire, terms and abbreviations, and everyone kind of scratches their head. So just stop us, please. Or if you just want us to explain why we think something or why we're using a treatment, always stop us, because it's helpful.